Greetings, everybody. We're ready to start our session. Can everybody hear us loud and clear? Please indicate on the chat. And can you check the chat?
Yeah, there it is.
Okay, thank you. My name is Tanusha Singh. I'm the chair of the NIOH Outbreak Response Team, bringing you today's session. A very warm welcome to colleagues, especially new participants joining us from the NHLS, that's the National Health Laboratory Services, and the NIOH, the National Institute for Occupational Health. We are a complementary division like the NICD, which many of you are familiar with. However, our primary goal is looking at occupational health issues in the workplace, ensuring healthy and safe and sustainable workplaces. Thank you very much for joining today's session, Return to Work. This is an important session as it impacts both on the employer and the employees, and they have many concerns of what to do in terms of a positive case, returning to work, as well as what to do in terms of returning to work post-lockdown. And based on Professor Karim's presentation that was done about a week ago, he indicated to us that we are yet to see an exponential increase in the number of cases as we see this third wave of cases from community transmission. So that will have a profound impact on workplaces. And today the panel is going to unpack some of these challenges in terms of medical surveillance, fitness to work, as well as decontamination processes that apply in terms of COVID-19. As many of you will know, we have been doing a series of these sessions, and all our material is available on the NIOH website, and the website will be displayed towards the end of the session, and you're most welcome to go and visit the website for further information. All our sessions is recorded, and during the session you will be muted. However, please make what's the name of the Q&A tab so that you can post all your questions. At the end of the session, we will have a session where the panel will respond to some of the questions. I don't think we will have time to respond to all the questions, but we endeavor to respond to the questions and communicate to the participants via email or through our website. Just to make an announcement of our upcoming sessions, we will be having a training session for environmental health practitioners on Friday, and next week we will be doing training particularly aimed for the food industry, as well as doing a step-by-step risk assessment in lieu of coming back to work and us revisiting the risk assessment when that happens. And an invitation will be sent to the participants via email. And once again, thank you so much for joining the session, and I hand you over to our program director, Mr. Ashraf Raycliffe, who will take you through the event for today.
Thank you very much, Tanisha. So again, welcome to the National Institute for Occupational Health Zoom webinar session. It's probably, I think, the 19th or 20th one we've had, and there are many more requests coming through for these sessions as covered by Dr. Singh. Dr. Tanusha Singh is the head of our COVID-19 outbreak response team, and also guides the work of our Zoom team for these sessions. So just briefly, I need to quickly introduce you to the NHLS. We are a part of a significant large organization with over 7,500 employees running over, I think, 356 laboratories. So it's the largest diagnostic pathology service in South Africa. We provide laboratory and public related health service to more than 80% of our fellow citizens. And we support the National Department of Health as well as all of the provincial health departments. As I've mentioned, there's more than 7,500 workers running the laboratory and scientific and other research, etc. expertise. We are the NIH, it's part of that. There's 356 laboratories, I've mentioned, over 260 sites in all of the 9 provinces. There are 6 regional offices of the NHLS, apart from the specialized divisions like the NIH and NICD. And then we have capacity within the National Health Laboratory Service for over 30,000 diagnostic tests, and I suspect that number's probably shifted and changed. We'll check up on that for you. That's within the NHIS, also including the NICD, which is COVID-19 specific testing, and the private laboratories. And then finally, our key sister organization is the NICD, which is responsible for the public health response for COVID-19 in support of the National Department of Health and the National Minister of Health. And then finally ourselves, the NIH. On the next slide, Glenn, we will see the NIH details, and I think it's important for you just to tell us who we are as the specialized institute dealing with occupational health. And there you have the quick brief bubbles indicating we have specialized services we provide, and that services is not just ergonomic, it's not just epidemiological, and it's not just sort of laboratory type services. It engages occupational hygiene, occupational medicine, immunology, and is it bio? I'll get back to that one. Pathology services, toxicology, analytical services in terms of organic and inorganic chemicals, etc. Teaching and training is where we are now, including this particular Zoom session, and we do a lot of other training sessions for particularly occupational health professionals, as well as people in workplaces. Knowledge generation involves our research. We've got 3 libraries that assist in this, and full-time librarians that can assist you with research-related and information generated by the NIH sections and researchers. Our advisory services includes our current hotline, which is manned, which is run by our occupational medical practitioners. The hotline number will be made available to you later on. And critically, all of this is now being under the outbreak response we're dealing with. That's the NIH. So thanks for just listening to our introducing the organizations. Thanks, Glenn. So the program for you that we have, we've had the welcome by Dr. Tanusha Singh, who's also the head of our outbreak team and head of the immunology section. Our first colleague dealing with return to work and workplace preparedness is Dr. Mpumi Daba. Mpumi will be on next. Following her is my other colleague, Anika Matuka, who's dealing with a critical part of return to work, and that is preparing our workplaces to be COVID-19 free and clean and decontaminated. Following that is Dr. Odette Volmink, that's going to deal with medical surveillance and fitness for duty for workers. There's a section that's going to be dealt with, I think, again by Dr. Ndaba, by Mpumi, on mental health. And then finally, we're going to end with compensation issues. Without much ado, I'm going to ask you please to use the Q&A box at the bottom of your screen. At the bottom, that's where you type all your questions on the presentations. We are going to endeavor to deal with all of your questions, or most of them, during the session. And those questions we don't deal with, we are going to address it through the website, our frequently asked questions, and we are going to alert you to those additional other resources there. We have had more than 2,000 registrants. Our license on Zoom that we have at the moment has a capacity of 1,000. And therefore, for those who could not manage to get on, we will send them a communication to apologize. And we are considering a repeat of this return to work session. I'm now going to call a reminder, please type your questions in the Q&A box at the bottom, and we will address them as we go on. I'm now handing over to my colleague, Dr. Mpumi Ndaba, to join us on the question of return to work and workplace preparedness.
Good morning, colleagues. My name is Mpumi Ndaba. I'm from the Occupational Medicine section of the NIOH, National Institute for Occupational Health. We're going to be touching on the basics, just a quick update on COVID from what we know to date with regards to the workplace. I'll just share with you, we probably know there's even more websites now, the websites that we use to stay up to date with information. And as we know, currently we've got about more than 2 million cases globally and 64,000 deaths. As at the 20th of April, there was about 3 p.m. yesterday. And in the South African context, we had 3,158 cases at around 3 p.m. yesterday, and the number had gone up by the evening. And the deaths were 54, but overnight the deaths have gone up to, the deaths have gone up to 58. So currently where we are in South Africa with regards to COVID-19 cases, according to the NICD website, and what we know, we had a lockdown from the 20th of March, and the lockdown was extended, and we are hopeful for upliftment after the 30th of April 2020. And we, at this stage, we know that we are beyond the travel-acquired spread, but we also have community-acquired spread. And from the numbers that we know, that we are certain about, we don't have numbers really, but we know that from the occupational perspective, currently we know there are health workers that have been typically been identified to have had occupational transmission. Just going through what we've gone through is going to be a very quick update. We know that the transmission is through direct contact, touching an ill person or contaminated surface. There's also a droplet transmission where when someone is sneezing or coughing, droplets of different sizes. We know that larger droplets, because of gravity, they fall to the ground within 1 to 2 meter radius of the person within a few seconds, and then the smaller one can travel further. And then an update on the persistence. We're familiar with this slide. We know that the virus that causes COVID-19 has a fragile outer membrane and less stable in the environment. But then the survival time differs in the environment according to pH, size of the inoculum, dryness of the area, temperature and exposure to disinfectant, and the type of the surface where it falls on. And on the right-hand below, on the right-hand corner of the slide, it shows the lifespan of the virus on different surfaces. I believe we've had this.
Okay, so we're just pausing for a moment. We are just going to turn the presentations into the slide mode. We've been asked by our presenters. It's at the moment in the pause mode. So apologies for that for me. Okay. Yeah, I think it's not the right mode. Thanks.
Okay, still on the update, I just spoke about we know the coronavirus lifespan, how long it lasts on different surfaces. If you look at surgical gloves, you look at plastic, glass, and various surfaces that it can land on in our workplaces. And talking from workplace preparedness, from the previous presentations, and now moving forward, and we need to look into what is the anticipated number of staff. We're thinking of opening up services, you know, and some of our services are employee public shared spaces, and then we're looking at the risk assessment that we're talking about that we have done. And with the risk assessment, we said specifically looking at the potential for increased risk of transmission. So in the risk assessment, we're looking at the actual operations that are associated with the increased risk of transmission, the activities, the shared spaces, and then the people in those shared spaces. Where the shared spaces are for the employees and the public, we don't only look at our employees, we consider also other people who might be in those spaces. From the return to work perspective, we know that the workplace is expecting a lot of people to come back, either people coming from lockdown, or from isolation, or from quarantine, or some people who may coincidentally have been away from work. All these people were anticipating to come back to the workplace after lockdown. And some of the workplace changes that have been made so far and the considerations include some of the engineering controls that might have been made, some of the administrative control substitution, and PPE. And what is of significance is with regards to administrative controls, some of the recommendations came from, from other legislation in terms of social distancing and looking at more office space, working off-site. Is this the time that we should think of maybe we could permanently have other people working off-site or limited contact, working facilities or workplace facilities? Do we have the ablution facilities? And then access control for staff, for visitors, dedicated, streamlined, and controlled accesses. These are all the procedures that we need to look at and all the amenities that we need to look at from the workplace perspective. So some of the non-medical management preparations, because my colleagues are going to be covering the medical management preparations. At this time, we need to look into, as part of administrative controls as well, debriefing, thinking of new changes, what's going to happen, or the changes that we have planned, how are we going to share them with people who are not at the workplace? How are we going to offer psychological support? How are we going to arrange, make sure there's new work organization, as I alluded to, and access control, as I've mentioned, and some of the special arrangements, and cleaning and disinfection is of primary importance at this time. So we also need to think of, as part of making people aware, we need to sensitize skeleton staff. Some other workplaces had people who had remained behind. So even though that skeleton staff, essential staff, or people in essential services, we need to look into training them on new procedures that might be effective after the lockdown has been uplifted. Remember, these people would have been in the workplace, they're still continuing on what they knew before. And then we need to communicate with staff at home. We need to look at the key operational people, HR, access control personnel. People need to know who to ask, what should happen when something happens, an incident happens, and what should happen for the access control personnel. What if I find 1, 2, 3, 4? Those are the procedures, training and awareness that we need to be conducting at this time. So also we need to clearly define the procedures to be followed. Remember, it's not business as usual, so there might be new procedures too, or changes from the existing procedures, and we might need to review the procedures that were in place. And out of all of this, I know people were very much concerned about confidentiality versus the public health outbreak, and the issue has been addressed that this is an issue of public health importance. So some of the issues around confidentiality, from a clinical perspective, yes, we can maintain those, but some of the issues might mean even disclosure, and other issues might need to involve actual management or line managers. So some of what we've spoken about in terms of mitigation of risk in the workplace, we've looked at primary prevention, where we need to look at means to minimize risk of transmission in the workplace. Like I said, we'll be having people who are coming back, they've been working from home, they want to know, am I protected? What should I do to be protected? There are people who are coming from quarantine who may have been declared that they can go back to work or they are fit, but we need to be sure that there is no risk of transmission, from the workplace, from people who are not coming in with conditions, but some people might have symptoms appearing while they're in the workplace. And at the same time, we need to think of how all of this is going to affect business continuity and how pandemic preparedness is in place in terms of the policies in the workplace. Some policies might need to be reviewed, to be checked, and to be actually customized to this COVID environment. We also need to focus on education and training as means of risk communication as well. So in terms of the key prevention measures from the workplace, we need to ensure that there are facilities to wash hands, or if not, sanitizing. And we need to communicate the cough etiquette and hygiene in the workplace. We need also to continue communicating to our workplaces, or our people coming back to the workplace, avoid touching eyes, nose, and mouth with their hands. And also emphasize the issue of cleaning, which my colleague is going to cover after me. Just as a reminder, these are some of the few prevention practices that we should not forget to ensure that in whatever we do in our workplaces, we've made sure that we've customized or adapted our practices to these prevention practices. And as part of minimizing risk of transmission in the workplace, some of the practices include screening and identification of potentially affected employees, limit contact and movement. I need to emphasize on this point that at this point we are screening people coming back, but those who already have disease, there is no need for them to be coming back, but they need to be reporting, because we know that they've been diagnosed with the disease. They need to go through the normal quarantine or isolation as recommended. However, as people come back to the workplace, there might be new cases, and this is going to be discussed in detail by my colleague in terms of how do we identify potentially affected employees, how do we limit contact while we work, and how do we limit movement in the workplace. And of utmost importance is to ensure social distancing in the workplace. The rest I've spoken to. So some of the workplace practices to review as people come back is looking at mass gatherings. So water, coffee stations, common areas. We recall that some people are coming from home, so some people might be looking forward to actually mingling with other people, but these are the areas we need to look into. Waiting areas, be it a clinic, be it the medicals where people are waiting, those are areas where we need to ensure that mass gatherings are avoided or are tried to minimize. Meeting, can we use other forums for meeting, online forums? But also some of the specific procedures, for example, spirometry in occupational clinical settings, and then consider another method and consider risk, but also there are other breathalyzers in terms of safety risk. These are the procedures or the policies that we need to take as an organization, or we should have taken by now. How are we going to deal with these in our different workplaces as people come back? Because ordinarily we would have said when you've been away from the workplace, maybe when you come back, we need to have some tests done at the clinic. How are we going to ensure that we're moving away from gathering people in big numbers? And looking at access control methods and also public spaces, which are also places of work for our workers. So in summary, the presentations that are going to follow are going to focus on medical management. Initially, there's going to be my colleague talking to workplace cleaning and disinfection protocols before people come back with the current staff in the workplace, ensuring that people come back to a clean workplace which will be safe and assuring to people coming back. Medical fitness issues and return to work issues, mental health issues, impairment assessment and compensation, and some aspects of work restriction. Thank you.
Okay. Thank you very much, Mpumi. That is the section dealing with return to work and workplace preparedness. I think an important basis and foundation for the rest of our topics. We now have my colleague here, Anika Matuka, who's going to deal with cleaning and decontamination, a very important aspect since you'll be receiving your employees back to work who are on lockdown and working from home, and those who are just, maybe quarantining or self-isolating. Anika?
Thank you, Ash.
Thank you.
Good morning, everyone. I'm going to present to you cleaning and decontamination procedures, which forms the critical component of infection prevention and control in keeping our environment clean, as well as protecting our workers in the workplace. So we need to differentiate between the two terminologies. We have cleaning, which is removal of foreign materials from objects using water with detergents or soap, but it does not kill the virus. Although the decontamination is a process which will kill the virus, and that should be done only after cleaning has been performed using the relevant disinfectants or chemicals. So the use of correct disinfectants is important in reducing or preventing the spread of COVID-19. Disinfectants may not work on all surfaces because you get different surfaces. You get the porous surfaces, you get semi-porous surfaces, then you get the non-porous surfaces. The disinfectants are likely to work best on non-porous surfaces. And then for other surfaces, you may need other alternatives, such as your surface disinfection devices, and as well as your sterilants or washing machines, which you can use for the laundry with soap or detergent and warm water. Some disinfectants can be toxic, so following safety procedures is important. I will cover the safety measures in the next slides. And then they can also be expensive. So whoever is going to use the disinfectants must make sure that they discuss this with their procurement department in order to budget for these chemicals,
so that we have adequate supply in the workplaces when we go back, or even now for those who are at work. So the World Health Organization and Centers for Disease Control and Prevention recommend that appropriate disinfectants with proven activity against envelope viruses, such as your coronavirus, be used to minimize the risk of transmission of the disease. And such chemicals must contain active ingredients, either as a single ingredient, some will come combined in a chemical or the disinfectant to be used. And those include your hypochlorite solutions, which is commonly known as bleach or jig. Then you get your alcohols, which should at least be 60%, but preferably 70%, as you know that the higher the concentration, the better you are able to inactivate your microorganisms. Then you get your hydrogen peroxide, you get phenols, as well as quaternary ammonium compounds. So you get different types of disinfectants. You get those that clean the surface and those for the hand, which we use as sanitizers. So for surface, you get the liquids, which can come either ready-made or ready to use, or which needs to be diluted. So you need to follow manufacturer instructions in this regard. Then you get the powders, which need to be diluted to form a concentration that you will need to disinfect. And the frequently touched surfaces should be disinfected regularly. So those include your shared equipment, as well as your doorknobs, the toilet seats, because we share toilets, and as well as your personal items, such as your desks or your computers, your phones, landlines, your bed rails for those in hospitals, as well as iPads that are used for those that are isolated, or even in office environment or any other workplace. And then for hands, you get the antimicrobial soaps, you can get liquids as well as gels or wipes. So the hands should be cleaned at the entrances or at the doors, and also at regular intervals. The regular intervals will depend on what activities you use, but it's mainly before either you touch a clean surface, or you touch your food, or you handle a patient in hospital cases, or even after blowing your nose, or going from the restrooms and so forth. So the sanitizers must be allowed to dry before any activity can take place, and it doesn't require any rinsing when you're using the gel type. So the most important thing also is to follow proper hand wash techniques. We know the most important 5 moments of washing, which is wetting your hands, lathering, and scrubbing, rinsing, and as well as making sure your hands are dry after washing. So the effectiveness of disinfectants depends on several factors. Those are your concentration that is required, as I've mentioned. You need to follow either the product label or the MSDS, which will guide you on what concentration should be made or prepared for the disinfectants. Some of them will come ready to use, and they will mention the percentage effectiveness on the containers, such as your 99.9%. So you'll know more or less the effectiveness of that chemical. And whereas some will tell you how much volume, for example, 2 ml, that's needed if you're using the gel sanitizer, for example. So the ingredients is also important. As I've mentioned, the active ingredients on the first slide, that should be considered for the coronaviruses. There are many products in the market, and just ensure that you get those that can target the virus, because some will only indicate bacteria, but we are not sure if effectiveness has been tested against the virus. So storage of products also is important. As the higher the temperature, the higher the genocidal activity. So it must be stored properly also, as temperature can also sometimes degrade the microbicidal activity of the product. Relative humidity influences activity of gaseous disinfectants. Those are, for example, your ethylene dioxide that can be used to sterilize in the room. Then you get your pH, which can increase antimicrobial activity of certain ingredients such as your quaternary ammonium compounds, but can reduce the activity of phenols. So pH has to also be taken into consideration, as well as the contact time. The contact time is the time it takes for the disinfectant to remain on the surface and to be able to kill the virus. You'll see on the next slide, I'm going to show you examples of different products with different contact times. And the container also will give you more or less the information on the compliance of which standard they followed when they prepared the disinfectants. So that has to be looked at. It will either also be on the material safety data sheet, or it will be on the product label. So there are certain safety measures to consider when using cleaning agents and disinfectants. I've mentioned material data safety sheets, which is important because it gives you information about the product that you'll be using. It includes your safety measures, includes the composition, includes the emergency procedures which to follow, and where there is a spill, what to do. So that has the critical information. The user must make sure they familiarize themselves with the material data safety sheet before they even start using the chemicals. So they must follow the product label and the instructions on the label. And after using the disinfectants, they must make sure they wash their hands properly and also moisturize hands to prevent skin irritation, as some chemicals can cause skin irritation. So where disinfectants are used, there should be adequate ventilation in that room, either in the form of natural ventilation, of open windows, supplementing it with a fan which will help in air mixing, or if there is mechanical ventilation in place, that can be used as well. And most importantly, the users or the cleaners should be properly trained, and they must be provided with personal protective equipment, the relevant ones for using the chemical. And the employees must be encouraged to report potential exposure as soon as possible so that they can get help or medical help on time. So this is a list of EPA approved disinfectants. You will find it on the EPA website that's shown at the bottom, right at the bottom of the slide there. There's a whole lot of lists. I've just extracted a small portion of that. But just to show you that there are different active ingredients, as I've mentioned, the quaternary ammonium, the phenolic compounds as well. You can see from the slides, those have the same contact time. And then you get sodium hypochlorite, that's your bleach, that has a 1 minute contact time. Then you get your hydrogen peroxide, which have the 5 minute contact time. So depending on your activity and how fast your procedures are, like in emergency cases, like in your ICUs, you'll want to use disinfectant with a shorter contact time so that the work can carry on. So these are just examples of products that you find. I just wanted here to show that as I've mentioned, that the product label will give you information. You see this product has got 70% alcohol, and then it shows the expiry date, the shelf life of 2 years, whereas this one here right at the bottom didn't have an expiry date. So it's important to look at the expiry date, because that determines the microbicidal activity and how stable the product can be. If you use it beyond expiry date, it might not kill the virus. So you'll be decontaminating, but there won't be any effectiveness. So check the products as I've mentioned. It will say it's killing 99.9%, but this was tested against bacteria, and on its label shows, it's actually mentioned the type of bacteria that it was tested against. So you will not want to use this for the virus if you are not sure of effectiveness of the product. So they either come undiluted, as I've said, and then just to mention that what I've just said now, check if it's antiviral, because you cannot interchange, they are not interchangeable. You cannot use a disinfectant for bacteria for the virus if it has not been proven to be effective against the virus. And then it will tell you the amount of how much to use. For example, one will say 1 pump is equivalent for 3 meals, and then the contact time, it will state also. But as mentioned, this one didn't have either the expiry date or the percentage alcohol wasn't indicated. So this is just an example of MSDS. This is showing you the recommended use for the chemical or the product. So for your cleaners, they must be trained that each chemical must be used for a specific purpose, because you find out that sometimes in the workplace, the cleaner seems to just take any container and use it maybe for the floor cleaning, whereas that's for something else. So they must be trained properly before they apply the disinfectants. And then it will show you the chemical nature of the product, whether it's flammable or not. There's a safety precaution, and then it will tell you also the category where the chemical is being classified. So I'm sure you have seen this on TV recently, where a hospital in Limpopo was being deep cleaned using, I'm not sure if it was a mist or gas, but you can see here the droplets coming out of the instrument. So it must be taken into consideration before doing cleaning. Check the supplier. This cleaning process was done by a reputable company which has been in the field for a long time and is experienced in cleaning. So there will be some suppliers, just ensure that they are registered suppliers and they are reputable. So also discuss the method of cleaning with the supplier prior to disinfecting, and then the contractor must also provide the effectiveness report of the chemicals that they are using in killing the virus, and then they must tell you of the procedure to be used. You must take into consideration also the types of surfaces, because as some procedures may not be aligned to the type of surfaces you have. Like for example, the hood, you don't want the hood to get wet while cleaning. If you have dry walls also, it's made of material that is not impervious. And then the CDC recommends the 28-hour waiting period before cleaning for those areas with high capacity, such as your schools or your centers and so on. However, some information for hospitals is that in ordinary rooms, the room can be cleaned immediately after the patient have left. But in aerosol generating procedures where it's conducted, then there must be 1 hour waiting period for areas with 6 air changes per hour, and then those with negative pressure or 12 air changes per hour, the waiting period is 30 minutes before it can be cleaned. And the workers must make sure they have signage on the door for those rooms that has been that are going to be cleaned during the waiting time, and then only remove the signage when it's ready for clean and can inform other people or the workers that the room is being cleaned. And adequate ventilation must also be ensured in those rooms while waiting so that it helps to clear out the air, and the areas must be closed off before cleaning. So where to from here as you prepare to go back to work? You need to first review company risk assessment for COVID-19. You may have the existing risk assessment report already, but if you haven't included COVID-19, this is time to include it. Check what existing measures do you have in place and whether you need additional controls in place. In the next week, we're going to cover full-on risk assessment on what control measures to follow and how to conduct risk assessment. And there are also slides on our website, the NIOH website, of the previous risk assessments that has been done for you to get more information on that. So employer must also ensure adequate supply of washing facilities where people can do their hand washing, as well as the cleaning materials, which include your detergents and disinfectants for healthy hygiene practices, as well as hand sanitizers, which should be accessible at the critical areas, at the main entrances of all the departments, at, for example, your lifts, which are shared by people, and at your changing rooms, and so on. So based on your risk assessment, you'll identify those areas and make sure you have the hand sanitizers there, especially where water is not accessible. That's where you should have sanitizers. And then dedicated PPE for all areas, because cleaning PPE shouldn't be moved around because we want to minimize cross-contamination to other areas. And the manufacturer instruction must be followed. And for those cleaners that are using reusable gloves, it is recommended that extra pairs of those gloves are allocated in the case where they need to disinfect. After cleaning, they need to soak those reusable gloves in a disinfectant, and they need to make sure that gloves are dry before they use it. So in case they are not properly dried, they can have an extra pair to use in the meantime. And then the next step is also to update your policies, your standard operating procedures, as well as your work instructions that you have in place. Those that should include procurement, review your contractors, and if possible, let them bring the samples to the workplace so that you see that's the product you would like to use, and then also supply you with the information related to the products. Check what control measures you have in place, and then the application of those disinfectants, check if they are being used properly. The facility manager must ensure they supervise the cleaners to see that they are applying proper PPE and using the chemicals properly, and that disposal is done properly also, and then how to manage spills in the workplace. Also review that and include it in all your procedures. Ensure that your training program is in place and that all workers are trained, those that are cleaning and as well as normal staff who's in the workplace, so that they know of their risks and then on how to protect themselves. Also health promotion campaigns in order to remind people of the danger of this virus, as well as inform them of information, new information, as we know that this virus is evolving and there's more information coming in. So they need to be updated on the information. Then on your risk assessment, you're going to identify your hotspots and make sure you prioritize the high risk areas, not neglecting the other areas, but just making sure that you follow the hierarchy of controls and you minimize the risk as far as possible. And then I've just listed the recommended sites where you can get extra information. There's a whole lot of information on the WHO and CDC website, the EPA website. I've mentioned it has the list of approved disinfectants. You can go through it and check which chemicals you think you can use for different surfaces that we have mentioned. Thank you.
Thank you very much, Annika. That is Annika Matuka of the immunology section dealing with cleaning and decontamination, a very important step you have to undertake when you are going to receive your employees back post-lockdown, even for some of those who are already working even during lockdown in some of the essential services. Our next presenter is Dr. Odette Volning, dealing with medical surveillance and fitness for duty for workers. Welcome, Odette.
Thank you so much. Good morning, everybody, and thank you for joining us today. Following on from my colleagues, we're going to be speaking to medical surveillance and fitness for duty within the workplace in this era of COVID-19. So, as always, we are guided, what we do in our workplaces with regards to occupational health and safety is guided by the Occupational Health and Safety Act, and particularly now the Hazardous Biological Agents Regulation. And in terms of defining what kind of hazardous biological agent this is, it seems to be a group 4 hazardous biological agent because it causes severe human disease. It's a serious hazard to exposed people, and it may present a high risk of spreading into the community. And there is currently no effective prophylaxis and no treatment available. And why this regulation applies is that with regards to the scope of the hazardous biological agents regulation, it deals with workplaces where a hazardous biological agent is deliberately produced, processed, used, handled, stored, or transported. So like the high-risk workplaces like healthcare industry, but it also it's also indicated where there may not be a deliberate intention to work with this agent, but as a result, people are being exposed to this hazardous biological agent in their performance of work, so within the workplace, with regards to colleagues and the public. So just brushing up again in terms of what is medical surveillance. Medical surveillance, it describes the activities that basically target any health changes of a person who is exposed to hazards within the workplace. And it's a longitudinal study of these examinations, medical tests. And medical screening is a part of medical surveillance, which is actually designed to detect the early signs of work-related illnesses. And this can be done by different testing modalities, which could include using tools like questionnaires, physical examinations, as well as medical examinations. My colleague spoke to primary prevention strategies within the workplace to mitigate hazards. This medical surveillance is a type of secondary prevention strategy and should always be used behind the implementation of engineering controls, administrative controls, as well as including work practices. And medical surveillance can also be used as a mechanism to determine whether the prevention strategies in terms of the hierarchy of controls are effective, or we are actually getting signs of early disease in our work population. So in terms of the elements of a medical surveillance program, just to recap, the first thing we need to do is to identify the groups of workers that actually require medical surveillance. And as all things done, they are based on the risk posed to these workers in the workplace. And particularly looking at COVID-19, the risks for actually acquiring COVID-19 in the workplace. Oftentimes, one of the elements is to do an initial medical exam with collection of medical and occupational histories, followed by periodical medical examinations or testing that are scheduled at scheduled intervals. Also, post an incident, sometimes examinations and screening needs to be done after an uncontrolled, like a spill in the workplace. But in this case, oftentimes after an infected person has come into our workplace. This medical surveillance programs also require ongoing data analysis. Worker training is essential to the medical surveillance program so that workers are able to recognize the symptoms of exposure to the hazard, in this case being COVID-19. A written protocol needs to be in place and appropriate record keeping needs to be done. And also, there needs to be specific actions in response to the identification of the hazard and the risks to the health by the employer. So, in line with COVID-19 risk, medical surveillance will be risk-based, and as the legislation says, should be determined at the guidance of the occupational medical practitioner. And the medical surveillance in the case of COVID-19 would allow for early detection of infected employees. And by detecting who is infected in our workplaces early, we can remove the infected individuals and isolate them. And also, these infected individuals can be referred early for appropriate treatment and care, so that hopefully that would have better outcomes, as well as allow them to have timeous return to work. But also it allows for us to prevent spread of COVID-19 within the workplace to unaffected staff, to consumers, to visitors, as well as clients. And this prompt identification and isolation allows for this and allows for quarantining to be done to separate sick individuals from not sick individuals, and allows for contact tracing to be done for other workers who are exposed to the infected individual in the workplaces, and it allows for effective return to work practices and work restrictions where necessary to come into play. Okay, my colleague spoke to this a little bit earlier, and it's the potential sources of exposure to COVID-19 in the workplace. And our workers can get it from the community. As we know, there's community spread of COVID-19. And so our workers can become infected in the community and bring this into the workplace. But also within the workplace, we can have exposures that we're dealing with regards to bodily fluids, maybe patient contact, maybe even contact with the public, as well as colleagues within the workplace. So those kind of situations that I mentioned would be more workplace or occupationally acquired COVID-19 exposure in the workplace. So who are our workers that are more at risk for getting occupationally acquired COVID-19? Definitely our healthcare workers, our frontline staff, like our emergency response, our public safety workers, people who deal with post-mortem care, laboratory workers, our airline operators, our retail workers who deal with the public, our border protection and transport security workers, correctional facilities workers. As we know, there's even been a hunger strike around people, as well as the prisoners affected. Our workers who work with solid waste and waste water management, environmental health workers, even our repair staff who come into homes of people could be at risk for getting COVID-19. And also people maybe not in the context we are in now when there's a travel ban, but when people travel to high-risk places, they're also at increased risk of occupationally acquired COVID-19. So even though we've spoken about the category of workers, even within each worker category, there are different risks risks within a group of workers. And our medical surveillance program always needs to be determined by the type of risk faced by our employees. So high-risk categories are people who have frequent, close contact, that's within 2 meters of people who are infected with COVID-19, or they have unprotected direct contact with infectious secretions or excretions of a person who is infected. Oftentimes, these types of workers include health workers, laboratory workers, and mortuary workers. And the very highest risk, even within this group, are the people who are present when aerosol generating procedures are done. They form the highest risk within these workforces. In terms of medium risk seems to be people who have frequent or close contact with people who may be infected with the SARS-CoV-2 virus, but they actually are not known, but are suspected to be COVID-19 positive. So these are people who have contact with the general public, like airline staff, the retail staff, people on border protection, public transport, drivers, public transport, as well as people who work in the correctional facilities. Now, the low-risk workers with regards to COVID-19, oftentimes these are people who don't really require contact with people, jobs that don't require contact with people who are either suspected or infected with, suspected of being infected with COVID-19. And often they don't require close contact with the general public. Now, there are different medical surveillance tools that are available for COVID-19, or the way these tools are administered. And this needs to be determined by the specific workplace according to what their resources are, as well as according to the risk that their employees face. So self-monitoring can be done. It's a tool that can be done, and it's often where employees themselves, and so we have to empower our employees to do this. The employees need to monitor themselves for fever by taking their temperature, recommended at least twice a day, and looking out for symptoms of COVID-19, which include fever, chills, cough, shortness of breath, sore throat, myalgia, and malaise. And these people, they need to be adequately trained if they're going to self-monitor, and they also should be provided with a plan of whom to contact should they develop any of the symptoms we spoke to. Then we have another tool that can be employed, which is active monitoring. And here there is regular communication with a potentially exposed employee who is at risk, with a member of the health team to assess for the presence of fever, of symptoms for COVID-19. And this is often used for employees with high exposure in the workplace. And this communication should be done with the employee to check, should be done at least once a day, and can be delegated by the occupational health or the infection control program. Then we kind of get a combination of the two, where we have self-monitoring with delegated supervision. And in these circumstances, the employee performs the self-monitoring with oversight by the occupational health or the infection control staff. And on the days that the employees are scheduled to work, the facility should consider things like measuring the temperature, as well as assessing the symptoms prior to starting a shift. This is but one example of a screening tool. This is a screening tool for essential health workers, but can be adapted. There are many types of screening tools. Some of these are available on the NICD website. But basically it looks at, this is one that looks at twice a day, a morning and an afternoon, recording of symptoms, including fever, chills, sore throat, shortness of breath, body aches, red eyes, loss of smell, nausea, vomiting, fatigue, and weakness. And the bottom ones are sort of the more not as common symptoms as the top, the top 4 symptoms. So in this is 7 days, but often for 14 days, if someone is exposed to an infected person, they would need to be monitored, or in the case of sort of passive monitoring or self-monitoring, this is a form that can be used. So the types of screening for COVID-19. We can have the symptom questionnaire that we looked at earlier. We can also look at fever screening, but caution must be made with regards to temperature screening, particularly in the workplace. Oftentimes it's measured as greater than 38 degrees Celsius or a subjective fever. But we must remember that fever can be intermittent and may not be present in some patients. So we may be, allowing, if we only do screening alone, temperature screening alone, we may allow people who are infected into our workplaces, because elderly, immunosuppressed people, or even people who are taking certain medications like non-steroidal anti-inflammatory drugs, could suppress the temperature, and this could be masked. So clinical judgment needs to be used to guide testing in such situations. And also we need to think about what happens where there are lower temperatures, like 37.5, maybe temperatures over that are not quite reaching the 38 degrees Celsius, but do have symptoms of muscle aches, nausea, vomiting, diarrhea, abdominal pain, headaches, runny nose, loss of taste and smell, and fatigue. These cases, we need to think about them, and maybe they need to be assessed by the OMP based on individual merit. So when we look at surveillance, we earlier said that it is determined by risk, and the high risk oftentimes require active surveillance. And people who have been exposed to a known patient oftentimes need to be isolated, as well as symptom monitoring to look for fever as well as symptoms. Those who have medium risk, oftentimes a self-monitoring tool may be used for up until 14 days after the last potential exposure. This would include checking their temperature twice a day and remaining alert for the symptoms. Should they be afebrile, asymptomatic, they should be checked that they are afebrile and asymptomatic before reporting to work, and sometimes even on going home if deemed necessary. And asymptomatic workers aren't actually restricted from work. People who have a low risk don't really require medical surveillance. Okay, so recommended procedure. This is just but one recommended procedure and should be tailor-made to your individual workplace. So the first thing is to determine the risk of COVID-19 to your employees, and what are the risk categories in your workplace. And then based on this, you need to think about screening of employees for COVID-19 related symptoms. And reporting, there needs to be a system of reporting such symptoms to a delegated person, ideally the occupational health practitioner. And then we also need to think about maybe putting in place at the start or at the end of shift a check that a designated person or the occupational health practitioner can do with employees to see whether or not within the last 24 hours they've experienced a sudden onset of the symptoms. And should an employee report any of the symptoms, they should immediately be provided with a surgical mask in the workplace and referred to the designated staff member at the workplace so that arrangements can be made for COVID testing should they report with the symptoms that are suggestive. And then if they report to for any additional symptoms or the more vague symptoms that could be COVID-19, they should be provided with a surgical mask as well as referred to the occupational health clinic, or even if it's their family practitioner or the primary care practitioner, for an evaluation to see if testing should be done. And then on receiving their results, the employee or the health professional should notify the workplace so that the employee is managed accordingly. And oftentimes the occupational health staff should actively follow up on these cases, just so that there isn't delaying in getting the results. Because if in the case of a positive result, this needs to be notified to NICD in line with what is required for public health measures, but also contact tracing needs to be done within the workplace for all the staff that the employee may have come into contact with. So within the workplace, there are certain protocols that need to be in place, and these need to be tailor-made and organization-specific. And some of these protocols that we need to think about having in our workplace need to be around in the event of a symptomatic person, what happens and what's the procedure to be followed. Should a symptomatic person be referred for testing and treatment? What happens should the person come back positive with regards to isolation, contact tracing? And we also need to think about return to work protocols of infected employees and what restrictions within our workplaces need to be in place following a return to work. These are some scenarios or workplace management algorithms that have been drawn up that offer quite a bit of guidance. And scenario 1 talks to a worker who has been a confirmed positive case within the workplace. And in a situation like this, the worker needs to be booked off and isolated. Disinfection of the workspace could be necessary, and these cases, in line with the public health requirements, the case needs to be reported to NICD and, if necessary, to the Department of Employment and Labour with regards to compensation if we feel that it is a work-acquired or occupationally acquired infection. The infected person needs to be isolated or quarantined outside of the workplace and ideally at home, and contact tracing needs to be done within the workplace. And then we need to look at return to work. When can this person return to work? There are different strategies that we can employ, which we'll talk to later, but oftentimes as a simple rule of thumb, patients can refer, infected people can sort of refer to the workplace within 14 days after the symptom onset, and that is kind of reserved for mild cases. But the guidance has also been that they can return to work 14 days after clinical stability. This is in cases of severe infection and severe outcomes. So that is sort of scenario 1, where we have a known positive patient in the workplace. Scenario 2 talks to the workplace algorithm or workplace management, where the worker has symptoms. So we've tested the worker. They have symptoms that are potentially, they have acute respiratory infective symptoms. So this worker needs to be looked at ideally by, or at least spoken to by, the occupational health professional, and they then need to decide whether or not testing for COVID-19 is appropriate, and based on the testing results, follow up on the testing. So if there's symptoms that actually don't fall under the classic COVID-19 symptoms. These people should be assessed by a health professional and a diagnosis made. If they feel it doesn't require testing, a diagnosis should be made, and people who have other conditions that are diagnosed then need to take the appropriate sick leave for those conditions. Or in the case where someone is tested and the test comes back negative, an alternative diagnosis could be sought and made and should also follow the normal sick leave procedures. So now these two algorithms are for COVID-19 exposed workers. And the first scenario, or scenario 3, talks to when a worker has been exposed to a confirmed COVID-19 exposure. The worker is asymptomatic. The first thing to do in that kind of scenario is to assess whether it was a high-risk exposure or a low-risk exposure. So with regards to high-risk exposure is when there's close contact, at least within 1 meter from the infected person, for 15 minutes or more, and the worker who has been exposed has not had PPE, or there's been a failure of the PPE, maybe the PPE was contaminated, torn, something, and there's been direct contact with the respiratory secretions from that infected person. So that is a high-risk worker or high risk of exposure. And in these situations, it's important for the line manager to sort of assess and to confirm the exposure risk as being high. And then certain protocols need to fall into place. They need to be isolated, and a report needs to be done of exposure to the NICDs, particularly in healthcare worker settings. Self-isolation needs to be at home for ideally 14 days as per the guidance, and with symptom check, daily symptom check and temperature monitoring until 14 days after the last exposure. Following this, an evaluation of the return to work needs to come in place. And if somebody has become symptomatic, they need to go on to treatment. They need to go on to testing, and if the testing is negative, following the period of isolation of 14 days, they can come back into the workplace. But if symptoms develop and they then need to be tested, and should they be tested and be positive, kind of goes back to scenario 1. So scenario 4 looks at exposed worker, but the exposure is more low risk of exposure. So this low risk of exposure is kind of defined as he's been more than 1 meter away from the affected individual or infected individual, or they were within 1 meter, but they were wearing adequate PPE covering their eyes, nose, and mouth. These people are kind of considered a low risk of exposure. So then they do need to report to the line manager. The line manager needs to assess the risk of exposure. And for low risk exposure, they can potentially continue working, but they need to self-monitor for the required period of time, which is 14 days. And if it is a case where it is a suspected case, but it's not a confirmed case, the occupational health team needs to follow up urgently on the case to see to get the test results. And if the test came back negative and the person wasn't actually COVID positive, no action is required. But if the case is positive, but the person wore full PPE, we continue to monitor for 14 days. And if symptoms develop, we go back to these scenarios. Okay, so now return to work. When are people excluded from work until? There's two kind of strategies that people spoke of. People have spoken about a test-based strategy where this is determined, or when they can return to the workplace is determined by the resolution of the fever without using any fever-reducing medication, as well as improvements in the respiratory symptoms, so they're not having coughs, shortness of breath, etc. And they have a negative COVID test result, PCR, from at least 2 consecutive swab specimens collected more than 24 hours apart. And then we have another strategy that has also been spoken about and been employed to look at return to work in people who have been COVID positive. And this looks at when all the symptoms have resolved, and sorry, that's not an or, that's an and 14 days have passed since the onset of the symptoms. So those are the 2 strategies that have been documented. So on return to work of the infected employee back into the workplace, all employees after isolation or quarantine period should follow sort of general work restrictions that include they need to undergo medical evaluation to confirm that they are fit to work. They should wear a surgical mask at all times while at work for a period of 21 days after the initial test. They need to employ all the common prevention strategies, including social distancing, adherence to hand hygiene, respiratory hygiene, cough etiquette. They should also continue to self-monitor for symptoms, and should symptoms recur or get worse, they need to seek medical re-evaluation. In the case of healthcare workers, it's also important that these workers post-infection should be restricted from working with immunocompromised patients. So now we're just going to go on to fitness for work. And just by recapping, fitness for work is basically a medical assessment that's done to determine if medically an employee can perform the job or the task under the conditions, the working conditions that are experienced at the time. So it takes into account the job specifications of the employee and the risks posed to that employee. And ideally, fitness for work should be done, and particularly in line with COVID, when there's been a significant change in workplace conditions, like now an additional hazard is coming to the fore, when there's a medical condition that a person has that may have severe outcomes due to the level of exposure of the hazard of COVID-19 by the job. And also for returning workers post-infection, looking at are they fit to still perform their work. So there has been a document in the UK that kind of classified clinically they called it clinically extremely vulnerable people. And these are people who may not be able to do high-risk work because they're so immunocompromised. And these include people who have solid organ transplants, cancer patients who are undergoing active chemotherapy, lung cancer patients who are undergoing radiotherapy, workers who have cancers of the blood or the bones, such as leukemias, lymphomas, myelomas, who are at any stage of their treatment, people who have immunotherapy or other antibody treatments for cancers, or workers who have targeted cancer treatments that can affect the immune system, who've had bone marrow or stem cell transplants in the last 6 months and who are still taking immunosuppressive drugs, people who have severe respiratory conditions, rare diseases, inborn errors of metabolism, people who are on immunosuppression, therapies sufficient to significantly increase their risk of infections, and pregnant women who also have significant heart disease, congenital or acquired. So those are the list of clinically extremely vulnerable people who may not be able to work in high-setting environments and may not be fit to work in a high-risk environment. But there's also, we know, other people who have documented to have poorer outcomes when faced with exposure to COVID, and who then get COVID-19 disease. So these are people who are over 60, they have cardiovascular disease. Their risk factors include diabetes, respiratory disease, chronic renal disease, possibly pregnant workers, employees who are immunosuppressive therapies, maybe systemic corticosteroids, or HIV diagnosed workers who are virally unsuppressed. So with regards to, these are also vulnerable people in the workplace, and assessments need to be made in terms of the severity of their conditions, whether or not their conditions can be controlled, and how much it actually would influence their immunosuppression. And these kind of considerations probably need to be made on a case-by-case basis, but would also determine whether someone is fit to work or not. So I know we've spoken about different scenarios for return to work and different strategies. They've also, we don't live in an ideal world. And there's been some documentation, particularly around health workers, where, other considerations can be made outside of keeping with the strategy we spoke about. And this takes into account what's happening on the ground. And so there's a document produced by the CDC that talks about, in limited or restricted resourced conditions, what people have employed. And it's important for facilities or for places to look at the local testing availability, and to see how the employers can also maintain the staffing levels when deciding on the best strategy to employ. So in some cases where testing was limited or rationed, certain facilities looked at non-testing strategies to determine when people can come back into the workplace in order to conserve the testing for those symptomatic patients. And in situations of critical staff shortages, where it is important to maintain the workforce for the public health, some facilities have discussed with local public health authorities and even allowed COVID infected health workers to return to work earlier than indicated in different countries. And this was determined on a case-by-case basis, and the facilities considered, due to restrictions, as well as only permitting this infected health worker, post-infected health worker, to only care for COVID-19 patients, or limiting them to a non-patient care activities. In other settings where there was a high community transmission, and it's known that the health workers are at increased risk, but when devoting resources to contact tracing and doing the risk assessment, sort of diverted the resources from more important infection prevention and control activities. Certain things were employed in different countries, and that some of these included reinforcing the need to adhere to the standard precautions for all patient encounters, stressing the importance of hand hygiene, cough etiquette, respiratory hygiene, enforcing social distancing between health workers and patients, instructing all health workers at the facility to report recognized symptoms, having staff regularly monitored, reminding staff to avoid reporting to work when ill. And when resources within became available, instructing staff to wear medical masks at all times in the facility. So these are just examples of, in different situations where there were severe restrictions and the rising epidemic, some kind of strategies that people didn't employ when they, when they were not able to fully utilize the best practices out there. Thank you for your attention.
Thank you very much for that, Violet. Our next session was going to be presented by our Executive Director, that's Dr. Spogana Mono. She's unfortunately been called to attend to an urgent meeting, EXCO meeting at the NHIS, the head office in Sandringham. Her colleague, Dr. Mpumi Ndaba, is going to present that session for us, and that's particularly on mental health. Did I just say your right name? Yes, please.
Thank you.
Thank you.
Hope it's still morning. Good morning, colleagues. We have a short, just a brief update on mental health issues, short presentation, but just to, allay anxiety, we are going to have a guideline, and these slides are going to be uploaded. I believe the guideline is already on our website. So we've spoken about a number of things that need to be done, but with regards to return to work and mental health, it's good that we sort of touch base that we cannot ignore. There's a lot of mental health issues that are happening, that people, there's a lot of anxiety and uncertainty that's happening. So in our current context, the lockdown itself has brought a lot of mental health issues, anxiety, uncertainty. Am I going to lose my job? How long am I supposed to stay at home? This change in guidelines, and this change in stages in our country. And living with the COVID-19, some people have actually had to live with COVID-19, the anxiety, am I going to make it? Returning to work, what if I'm exposed? Maybe I've been safe at home. And how will this return to work happen? How will the schools be phased in? How will everything happen? Is it safe? The biggest question people are asking is it safe? Should I ask for PPE even before I get back to that workplace so that I'm not in contact with anyone? So these are all sort of stressors, and people are in anxiety in different situations. Those who are at work are worried, are people going to come back and do their share and pull the load? Some people are working from home. I actually say they're working harder now that they're at home than at work. And, people are even scared that maybe we are saying, workplaces must debug. So how do we optimize, our staff preparedness and well-being and, functioning in this pandemic response? We're expecting people to come back, but given these uncertainties and given the anxiety that people have, how do we ensure that when they come back, they're functioning optimally? I'm going to start with a little bit of background of, the pandemic stages and where we are, and just explain what happens, in different pandemic stages. And the technical capacity that I'm going to refer to is typically a healthcare worker capacity, but it can apply also in any workplace. So the pandemic stage, the stage one, is that stage of preparedness for COVID-19. That was very early in March, when we're still sort of planning, anticipating how are people going to be coming in, gaining insight, what is this COVID, and so forth. And then the next phase was the early phase, where now we started seeing a number of cases coming in, and specifically for healthcare or health workers and other essential services. Now, there had to be potential, for caseloads, rethinking strategies, minimizing people approaching health centers and other, commonly shared places. And at that early phase now, we're trying to think, what is it that we're going to need for full technical capacity? But because the number of cases were very few, there was the issue of, yes, we have full capacity technically, we've got what it takes, we are ready. And then also the vigilance regarding sufficient resources. And there was also now beginning of some ethical dilemmas, we had doctors asking, should I continue to be working? Should dentists be operating now that we know these are the issues? And if I'm an essential worker, do I have a right to refuse to work? So those are all the issues that were happening around the early phase. Now we got to the mid phase, which we believe we're still in the mid phase, where now we've got quite a few, many new cases that are coming in daily. Like I said in the afternoon yesterday, I thought it was still 54, but at night, I realized, the change of 58 deaths, not just like cases. And also there's now strain on technical capacity. Remember, there's also the lockdown. A few people have to be at the workplace, child, men, whatever, more people could have done. But even though other people are working from home, but in terms of the technical capacity of what can be done now at the country level. So the next phase is the peak phase. We believe we are not there, maybe we are nearing there, where there is now case overload. There's insufficient capacity. We know other countries are already there, have been there as well. There's so many patient numbers that would flow to different facilities, and people will need sort of national review of boundaries in terms of scope of practice. But we know that has already happened in our South African context, where like for example, doctors have been allowed to use telehealth facility or means of consulting. But also there's no issue of it's only these people who can do that. A lot of people have come in to try and help here and there. Then the next phase will be the tail of phase, where the technical capacity is okay and there's minor ethical dilemmas, and because now the numbers are going down. But then what is important is that the tail of phase and the next phase, which is the post-COVID-19 phase, the timelines are not known. So, and then the post-COVID-19 phase is characterized by this full technical capacity. They still reduce fast functioning or reduce numbers, but at least because there's not a big load, then there's some technical capacity. People go back to do what they were meant to do or what they're supposed to be doing. So there's nothing like some of the sections of the hospitals or services are shut down, but life has gone back to normal. So, as I said, we believe we're in the mid-phase, and some of the staff challenges at this time is that, as I've said, there's high levels of distress and worry. People are worried about a whole lot of things. People are not coping, and some are already overwhelmed. And remember, in our setting, people are employees, but also the schools are closed, so people have to take care of how do I juggle between the two? How do I make sure that my family stays safe? For essential workers, how do I make sure that my family stays safe while I go out? And some people are actually on overdrive now, and then some people are also starting to deplete personal reserves, running on empty now, and some are trying to stay strong for patients. And there's also potential fear for reprisal, for difficulty, in terms of taking difficult decisions. And in terms of the staff actions, what we can recommend to staff is people should focus on the circle of influence. This is the time, as we say, that your key people that you trust in the workplace, at home, and have all those, just a few people that they're key in your life. Supportive teamwork, this is now in the workplace. Practice developing psychological and cognitive strategies. People must now learn coping strategies. Conscious attempts to establish, there have to be a routine for relaxation and sleep. I know that it's quite a difficult time, but now this is the time that people need to be taught or to be informed that they need to develop that routine. And while we're at this phase, stressful as it is, there's tendency for people to use alcohol or other substances to actually try and sustain their emotional well-being. It is very important that we are aware as people, as staff ourselves, that we need to avoid excessive use of alcohol during this phase. And what interventions for staff can be recommended from now a workplace perspective? We need to prioritize drinks, food, and rest, and make sure that we sleep enough. And then also we need to have strategic rest breaks and comfort breaks in the workplace. While people are coming back to the workplace, there have to be strategic rest breaks, and all of that should be incorporated in as part of supporting people. And there are also strategies for senior management and then some of the corporate-wide actions. These include active monitoring of staff well-being, like we said, not only now monitoring only the temperature and the symptoms for COVID-19, but also, are you still fine? And have these issues standing agenda on management meetings, regular communication channels, ensure successes are shared, no matter how small, but this is the time that people can do with, no matter how little, can do with some positive feedback. And also, we need to be vigilant to monitoring resource, adequacy. Some of the activities can be done offsite. Do we have all the support, all the resources that we need for that? So some of the new issues that have been reported during this time include stigma. This is an unusual one because ordinarily people, when coming back to work, this is a time where it's so unusual that people are actually excited to get back to work, only to find that there's a stigma or they're stigmatized in workplaces because they tested positive. Everyone is scared that you're going to sort of infect me. And there's issues of social isolation, People don't want to isolate, with don't want to interact with somebody who's coming back, maybe from isolation or quarantine. Not only physical distancing, but now social isolation and forgetting about people who are actually not around. There's a lot of anxiety and depression. And, taking back consideration that there are people who already had some of these conditions. So this is the time that they need reassurance, and it's happening to be getting worse. And also some of the issues include substance use, overuse, and abuse. People are trying to deal with this situation. So part of trying to reduce the stigma include, you separate the person from having an identity, defined by COVID-19. So some of the terms that we use as COVID-19 cases, the victims, COVID-19 families, the deceased, you need to do away with those. But we may refer to these people as people who have COVID-19, people who are being treated for, people who are recovering from. Because after people recover, life will go on with their jobs. But if we give them these titles, they remain with that whole sort of stigma attached to them. And some of the key focus areas that we should look into, including from the workplace, we have to be organized and communicate the business continuity plan. This is not for occupational health and safety or like a safety practice only, but it's part of ensuring that people, as people come back to the workplace, they're incorporated and they feel that the workplace is safe, and then the safety is part of, it's top of the mind and sort of minimize anxiety. And then those who've been previously identified as at risk for social or mental health issues, they need to be targeted at this time. We need to make sure that there's continuous, ongoing contact and support for them. All staff working remotely in quarantine and isolation, there has to be some contact from the workplace to be sure that everything is okay and identify early areas of abnormality. And also what's important is that we all need to support our leaders and, training on handling this unique situation. We need to accept that this is new to all of us. So some leaders are doing the best they can based on no other information. So we need also to be sure that we support leadership. The workplace has means of supporting leadership or people who are leading during this time, because there is increased pressure at this time to take decisions on a short time span or based on minimal or no information. So as people, each one of us, although we are providing a service, it's very important that we keep check of our individual mental fitness. We need to keep informed via reputable sources. There's a lot of media outlets and some other information that comes from all over, but we need to make sure that we keep to reputable authorities to get accurate information. And if people are in mandatory isolation, let's make sure that you maintain your social connectedness. You might be far from people, but be nearer by social connection networks. And then let's try and exercise daily, some minimal, even if it's not so much, but some exercise daily and factor it into your life. And also practice some mindfulness meditation each day. And then it's very important for people to remember that you are not alone. We are all going through this together. So before I close, I'd like to make aware people that the Department of Health Workers specific support is available for all of us. But I'll start with a list of where the Department of Health Workers can get support services during this time. The list is on the wall now. But also some other mental health issues in the workplace. We know that workplaces have EAP services, and sometimes these services are only maybe for substance use or abuse. We need to establish if these services can be scaled up to include even other mental health, especially around this time. And I'd like to make colleagues aware that the South African Depression and Anxiety Group, which is nationwide, which offers free telephonic counseling information. They have nationwide referrals. They can refer you to anyone. They've got a national footprint, and they can provide you with a counselor to speak to. They are there 365 days a year, 8 a.m. to 8 p.m. Lastly but not least, there is also in Gauteng, and Gauteng being the COVID-19 epicenter in South Africa, there's a mental health team that has been formed to support healthcare workers. This team is about a group of 14 private and public psychiatrists and psychologists in Gauteng, working inside the South African Society for Occupational, Society for Psychologists and Psychiatrists. And that is their website there. There's a webinar that they provided to the NIH, and because they are part of the SASOC will replicate whatever they are doing in Gauteng nationally. And this whatever service they offer, they say they are promising that they're offering 4 confidential pro bono sessions for healthcare workers specifically. And then first they also assist the leaders in terms of their approach, but also they link the individual with healthcare workers. So their approach is two-pronged. You know, they first sort of provide an immediate debriefing and sort of provide assistance with regards to preventative mental health care approach. And then secondly, there's also where they link. Now you log in, you talk to somebody, and then they link you with another volunteer mental health care provider around your region. So in this instance, it's Gauteng. And most of all, I think all of us will realize that, yes, there are issues about social distancing, but it doesn't mean that we need to distance ourselves socially. You know, we still need to stay connected in terms of other means. And as means of reassurance, we are all in this together. This is new to all of us. We don't know what will happen tomorrow, but we are in this together. So people can stay reassured. Thank you.
Thank you very much. That was Dr. Mpumi Ndaba. Mpumi, thank you very much for your contribution there. And standing in for our Executive Director, Dr. Spochalamono, unfortunately couldn't join us today. Our next presentation is on compensation issues. So this is after the fact, when there may be reasons by affected or infected employees and your support with that. And I now invite Dr. Samantha Yalu to deal with that particular issue. Thank you very much.
Good morning, everybody. I'm Samantha. I'm an occupational medicine specialist here at the NIOH, and I'll be dealing with compensation issues. Yes. Thanks. Good. All right, so the first slide. So obviously we start with our legislation. So first off, right at the back, we have the overarching Occupational Health and Safety Act, and attached to that, we have our hazardous biological agents regulation, of which our COVID belongs to, and it is a Schedule 4. It's a Schedule 4 agent. Then we have our Compensation for Occupational Injuries and Diseases Act 130 of 1993. Then we have our Notice on Compensation for Occupationally Acquired firstly, then we have our Compensation for Occupational Injuries and Diseases Act 93, as amended. That covers our compensation for injuries and diseases. But remember that it covers all our occupational injuries and diseases except in our minors, our chronic diseases in our minors. Yes. Then what we're going to be talking today a lot on is our notice on compensation for occupationally acquired novel coronavirus under the Compensation for Occupational Injuries and Diseases Act 130 of 1993. So next slide. So under the notice of compensation for occupationally acquired novel coronavirus disease, or COVID-19. So how do we, firstly, we need to know, is there an occupational exposure to a known source of COVID-19? So is there a reliable diagnosis of COVID-19? How do we know if there is a reliable diagnosis of COVID-19? So firstly, is there a reliable, how do we know if there's a diagnosis for occupationally acquired COVID-19? So the first thing we want to know is the occupational exposure to a known source of COVID-19. We want to know if there's a reliable diagnosis of COVID-19, and for this, we want to know if the reverse transcriptase PCR test has been done. So it's very important that a reverse transcriptase PCR test has been done. Especially going forward, we don't really want a rapid test. You know, those are going to have a lot of false positives. So we really need to have a PCR test. We want to find out if an approved official trip and travel history to a high-risk area, you know, if that has been, if a person has gone to this area, if there's a high-risk COVID work environment. It's important that there's a temporal association between the exposure and the symptoms. This is important because it's important that the symptoms, oh, can I go back? Oh, that the symptoms must precede, the exposure precedes the symptoms, so, and not the other way around. So that's how we know that, you know, that the diagnosis for an occupationally acquired COVID-19. So who is able to claim for occupationally acquired COVID-19? So all workers with a valid contract are able to claim for occupationally acquired COVID-19, except for those for domestic workers and those in informal trade. Yeah, those working at the side of the road unfortunately cannot. Our South African National Defence Force, our South African Police Services unfortunately cannot. Military people unfortunately cannot. Independent contractors, people who work outside the country for more than 12 months at the time of diagnosis cannot claim for occupationally acquired COVID. And any act of willful misconduct leading to the disease at the time of diagnosis. These people are unfortunately unable to claim for occupationally acquired COVID. So what makes COVID-19 occupationally acquired? So if a worker travels to for work purposes to a high-risk country, and that it makes it occupationally acquired, health workers, it's more likely to be occupationally acquired. proof of a close contact within the work environment, and then other considerations such as a high-density work environment, frequent contact within the work environment, frequent touch, frequent money exchange environments, poor ventilation within the environment, contact with vulnerable groups. So these are, risk factors that make COVID-19 more likely to be occupationally acquired. So which are the occupations at risk? So you have four groups according to the notice. You have very high risk group and a high exposure risk group, and these are essentially all your health workers. So your very high risk group is essentially your group that do your aerosol generating procedures. Then you have your high risk group, and those are your other healthcare workers. And it's important to note that your very high risk group and your high risk group can move between the two, depending on whether they do your aerosol generating procedures or not. So they move between those two risk groups. Then you have your medium exposure risk occupations, and those are your frequent close contacts within 2 meters of possible COVID patients. And those environments are your school environments, your labor centers, your retail, and those are, your workers that are within 2 meters of possible COVID patients. So frequent or close contacts within that environment. And then your low exposure risk groups, and those are people who are going to probably require a high motivation as to why they COVID is occupationally acquired, because those jobs do not require contact with people known to be suspected of being infected with COVID-19. So your potential sources of exposures in the workplace, this is sort of, everybody already knows this, but really it's direct transmission through fomites of touching different surfaces, droplet transmission, sneezing, talking through secretions, and then your aerosols. And that's through aerosol generating procedures, and those are mostly in your healthcare workers through doing different aerosol generating procedures such as intubation, your dentist through doing high-speed dentistry procedures. So once you've established that this is most likely occupationally acquired, the next step is your assessment of impairment and then benefits. So how do you assess impairment? This is done by your doctor, your specialist, your ONP, and this assessment is made once your maximal medical improvement is reached. And this is your degree of impairment is based on complications from the affected body system. So with COVID-19, this is most likely in your lungs or in the air, or the area, or once you have reached your maximal, once you have reached your maximal medical improvement. And most likely this is after a period of, usually at 2 years, that is your best improvement that you have made. And then your benefits, the benefits that you can claim compensation for are your temporary total disablement, and that is, so you are liable for, you can claim payment for less than 24 months. You can claim benefits for self-quarantine, and that is your employer is liable for your days of leave, but can claim that from your compensation. Then permanent disablement. So if your disablement lasts for more than 24 months, then you can claim for permanent disablement. If it's more than 30% disablement, then you can claim it in the form of benefits, in the form of pension, which you get paid out in a monthly form. That's every month you get a pension out. But if it's less than 30% or 30% disablement, then you get it in the form of a lump sum. You can also claim medical aid benefit, and then you also get a death benefit. And also, you can also claim funeral costs. So reporting. The following documents should be submitted to the Compensation Commissioner for his adjudication. So you need to submit an employer report of an occupational disease. So that form is called a WCL1. You need to submit a notice of an occupational disease and claim for compensation. That form is called a WCL14. You need to submit an exposure and medical questionnaire. I'll show you what that document looks like just now. You need to submit a first medical report in respect of an occupational disease. That's what a doctor or an OMP fills out. That is a WCL22. And exposure history, that's a WCL110. And or other employment history, a medical report from a doctor or a specialist. Then there's other progress medical reports. If there's a long progress or there's a long time to improvement, then there's a lot of progress reports that need to be filled out. That's a WCL26. And then there's finally a final medical report. That's also the same document. It's a WCL26, and that's once your maximal medical improvement has been reached. So there are some important considerations that need to be considered. So your first medical report, it should list the diagnosis as U07.1, and that is the ICD-10 code for COVID-19. You need to take an appropriate exposure history. And your appropriate exposure history is what you need to motivate to make the Compensation Commissioner aware that that the COVID is most likely occupationally acquired. So those are things like take into consideration things like the ventilation. If that's poor, then it's most likely, more likely to be occupationally acquired. Things like high crowd settings, frequent money exchange, if the environment is so. High touch environment, frequent money interface. These things are quite important to motivate as to why you think this is a high occupationally acquired. In your medical report or the doctor's medical report, comprehensive occupational history, the diagnosis, the lab results, the chest x-ray, all that information is very important. The vulnerable, if the person is a vulnerable population group, that's important. The examination is important. the baseline examination is important. All of that needs to be documented, because basically you are writing a motivation here. So especially if you want the compensation commissioner on your side, you need to document all the evidence as to why you think this is occupationally acquired. And then lastly, if the employee may need an affidavit if the employer cannot be traced. And this is sometimes the case because lots of the time the employer doesn't want to fill out the documents, or because he doesn't think it's occupationally acquired. Even if the employer doesn't think it's occupationally acquired, he still by law needs to fill out all the documents, even if it's suspected, or even if the employer believes that it may be occupationally acquired, the employer still needs to go through the process, because ultimately it's still the compensation commissioner who makes the ultimate claim, the ultimate decision as to whether it's occupationally acquired or not. Then the online claims and processing. So there's two ways you can submit the claim. You can do online claims and processing, or you can submit the claims manually. The employee can submit it themselves, or the employer usually submits it on behalf of the employee. And that's usually what we recommend. That's the best way. So this is the information for the on where we've gotten. Actually, I've gotten some queries yesterday about where to submit the claims. So this is the information about where to submit the claims. So you can look it up. It's actually in the notice. And so this is the information on the actual notice. And this is the COVID-19 exposure medical questionnaire that you submit with all your documents. You just fill it out. It's the exposure medical questionnaire. It gives you, you just fill out the information about the employee, employer information, and the employee needs to sign it. It gives you all the information. So at the end of the day, the compensation commissioner is ultimately makes the adjudication. He can ultimately repudiate or accept the claim. And if he repudiates the claim, you can lodge an objection, which is Section 92 of the COID Act. That gets reviewed by medical advisors. And if you're still not happy, you can take this up to the High Court. I think that's it. That's my acknowledgements. And thanks.
Thank you, Samantha. And that's our session dealing with the compensation issues. And just to recap quickly, our program for today has involved quite a number of those occupational medical specialists who are in fact answering our hotline. And I'm going to quickly ask Glenn to just put up a quick slide with regard to resources, just to remind you of our hotline, our email address, as well as our Twitter handle. I will also put that in the chat. So if people just, we will put the current session on silent, but I will, before we close the session, add some of the contact details also in our chat box. Now, our program today has dealt with the sequence of presentations, and on the slide you see now are key resources for you to go to. I must please emphasize and encourage you strongly to visit the NIH's website, the one at the top. You'll also see there's lots of COVID-19 workplace related resources there. The NICD website is below that, NHLS, our mother body, National Health Laboratory Services, Department of Health, the national website, Department of Employment and Labour, the World Health Organization, and then the Center for Disease Prevention and Control in the US, keeping in mind that their guidelines are very context specific, and we will need adaptation of those things for our context here. The International Labour Organization, thanks Glenn, and then a key hotline to remind you of is the NIH Occupational Health Practitioners Hotline, the 08002121751. That's an important one. The NICD Public Hotline, the NICD Healthcare Workers Hotline, and then also the National Department of Health's WhatsApp line. For queries, any queries and questions that you may not have had a chance to add to the session, just name the session itself in your subject line and send us an email to info@nih.ac.za. That's info@nih.ac.za. So we've covered the return to, thanks Glenn. So we've covered the return to work and workplace preparedness, cleaning and decontamination, medical surveillance and fitness for duty for workers, important for the workers returning to work, and the mental health and compensation issues. Unfortunately, we've run out of time today. This session will be repeated for those who didn't manage to log on today. We have a maximum of 1,000 login facility. We had more than 2,000 registrants this morning, and so only 1,000 to get on. We are repeating the session on Thursday. My colleague in the IT department, Tabani, is busy setting up the invite to register. Please log in early on Thursday morning if you don't want the maximum level to prevent you from logging on. And at this point, unfortunately, we cannot have our question and answer session that we planned. We've had so much in our first return to work session to present. We will reallocate our times and perhaps lengthen the session for Thursday. At this point, I need to say thank you very much. I'm Ashraf Raikler, the National Occupational Safety Training Manager at the NIH. On behalf of the COVID-19 Outbreak Response Team and its chairperson, Dr. Tanusha Singh, we say thank you very much for joining us today, and we look forward to you visiting our website where this recording, audio and video, and all the presentations will be uploaded, and the frequently asked questions will include questions you've raised today. Thank you very much for joining us.